Hello, my name is Brenda Jacobson. I'm the president of Mindful Communications, and I'm delighted to be hosting Dr. Rebekah Gee and Dr. Liza Swedarsky as part of the Healing Healthcare Summit. Our session is titled Imagining an America Without Health Disparities. How do we achieve access and equity for all? And we're set into the frame of today's overall theme, eliminating health disparities. From mindful anti-racism work to the practice of nonviolent communication and deep listening. Today, we are exploring how to heal disparities in healthcare and health outcomes and improve health access for all. As a marketing note, you can purchase lifetime access to all of our Healing Healthcare Summit content in a downloadable format at mindful.org/healthcare. Let me tell you a little bit more about our presenters today. Dr. Rebekah Gee is an innovative change agent, a leader in patient safety and quality, a physician, a public health policy expert. She's the founder of Nest Health and served as the secretary of the Louisiana Department of Health from 2016 to 2020. We also want to thank Dr. Gee for serving as co-chair for this event. She's informed a lot of our content and speakers, and we're grateful for all she's donated of her time and effort to ensure success. Dr. Liza Swedarsky is a gynecologist and minimally invasive surgeon who has dedicated her career to eliminating gynecological and surgical option disparities for women of all races and socioeconomic backgrounds. She has served in 7 of Boston's community health centers since 2006. She's also the founder of Health Vows and facilitates a 7-week program designed to empower women to navigate their healthcare journey. All right, let's start with you, Liza. What inspired you to found Health Vows?
So thank you, Brenda, for that question. Health Vows was born because I actually set an intention to figure out a way I could better serve women. I'd already been practicing gynecology and was finishing up my fellowship in minimally invasive surgery in Florida when I noticed there were so many women who just were not educated about what they actually needed for their bodies, what screening guidelines existed, were nervous to talk to doctors, had struggled to navigate these complex healthcare systems that exist. And they just found the experience frustrating. And during my time as a medical doctor, I'd worked in 4 Boston community health centers by that time, and had seen that, Black women were less likely to get offered a minimally invasive procedure. They were less likely to have pap smear screening. They were more likely to die early from breast cancer. And this was also true for immigrant women and poor white women. And so when I thought of what can I do to serve more, I feel that conscious change is key. Change and transformation begin in the mind. A decision to live healthily begin in the mind. So I created the 7-part workshop series that takes women through a journey of first self-love and self-acceptance. We talk about, dissipating fear, because most women are afraid of certain aspects of pursuing healthcare, or they're afraid to speak up and advocate for themselves. They're afraid to ask questions, oftentimes because they don't feel comfortable because of the way they've been treated or time constraints. We also talk about how to, handle the patient-doctor relationship, how to be an active participant. There's a part of the series that deals with self-advocacy and in knowing your history. And then we talk about eating healthily, exercise, and diet. And I also go over just what are prevention guideline measures, educating women about what they actually need. So Health Vows was born in me from a desire for women to take their power back from a healthcare system that isn't really serving them. We live more in a sick care system. And so if we can live more in the prevention lens, what can I do to make changes in my life? And then live from that lens, we can probably prevent many of the disease processes that show up later on. As we know, our health is so much more than what happens in that patient-doctor interaction that can be anywhere from 15 minutes to 45 minutes. Most of what happens that contributes to how healthy we are is really what's going on in our environment, our homes, access to education, food, housing, our health access to healthcare. And so Health Vows actually creates a space for conversations that women are not having or not comfortable having. So, you get a group of women who've never met, and there's a real deep sharing about, this journey of healthy living, starting from the inside out.
Wow.
Yeah.
Are you part of a cohort when you join the program? Is that when you talk about like the shared journey? Yeah, I can see that would be really supportive and almost could practice some of what you're trying to teach, right? Role modeling and perhaps.
Absolutely. There's a cohort right now. I limit the groups to 20 women, and with the height of the COVID-19 pandemic, I transitioned the entire series to Zoom, the Zoom platform. And the beautiful thing is we've had reach across the entire country. We've had some participants from Europe, and I set different times. And so at the most, we'll have 20 women, and we meet for 7 consecutive weeks for an hour and a half. Mindfulness is a huge part of the program. Every single week, we practice mindfulness. We start off with setting an intention for the time we're going to spend together. We practice meditation. We actually do a deep dive into what our conscious thinking is like, in terms of when we're approaching a situation or a healthcare question or a doctor's visit. We reframe fear and really get in touch with like what is going on in our minds and our bodies so we can better navigate that journey. Take our power back, because no one cares more about your health than you. You have to be your biggest advocate. And sometimes we don't feel worthy, or we don't feel comfortable, or we give our power away, when it should be a relationship.
Thank you. Rebekah, tell us about Nest. What inspired you to found Nest? And I think we're talking to you in your new office for Nest. Is that right?
Yes, this is my nest for my nest. But Liza, I so appreciate what you had to say about power, and that we have to take our own lives into our own hands and recognize that health is one of the most valuable currencies we have, and something that we have some control over, but the system isn't set up to optimize taking advantage. And I think that's partly why I'm so interested in this conference, is trying to think about how to help people take more control of their own lives, and especially those who are caregivers. Women so often are disproportionately caregivers. As clinicians, we are caregivers. And it's kind of like the mask on the plane. If you have your child on a plane, the stewardess will come and say, well, put your child's mask on first. It's kind of like that with providers. If I don't have empathy for myself, if I don't have self-actualization, if I am not at peace, then it's hard for me to provide those same feelings and that sense of well-being for my patients. So I think all of this is so important, and I'm really honored to be a part of it. So Nest Health was created out of gaps. Liza mentioned some of them, but I'm formerly Secretary of Health for the state of Louisiana. In that role, I spent almost $60 billion of public funds, about half the state budget per year, on things like disaster response and preparedness, how we eat safe foods and inspect them, aging services, disability services, public health, behavioral health, and our Medicaid program. And all of these things were important. I believe healthcare is a human right. In fact, Governor Edwards and I, he made the decision, and I was honored to lead for him the expansion of Medicaid, which now serves over 600,000 newly insured people in Louisiana. But the bottom line is insurance isn't enough. And the insurance market and the companies that provide services to it have not been focused on women and families. And so Nest Health was created because partly out of my own experience, I am a parent of 5 children, including 2 sets of twins. I have a busy job. I have a husband who won't go to a doctor unless I nudge him, make the appointment for him, and push him out the door. And so it all depends on me. And I'm busy and overwhelmed, and it's really hard to manage. All 5 of my children have diagnoses, some of them behavioral health needs that are great and challenging to manage. And I thought about, well, if it's this hard for me, think about a single mother. Think about a low-income family that doesn't have transportation, different appointments at different times, appointments at inconvenient locations, appointments when my hourly wage job won't pay me. if I take time off, if I go to that appointment. Also not understanding my needs. Who's ever come to my home? When you ask women who have just had a baby in America, almost 20% of them say no one has helped them. They have no one to turn to. And so out of that, and looking at my experience running the Medicaid program, I think the most important period of emphasis for improved health is early childhood, preconception through early childhood. If we can help mothers and fathers and their children develop through prior to pregnancy, through the pregnancy, to age 5 of those children, we can really set a wonderful start to that life course and make a big difference. And yet the programs and resources that we have for families are hard to navigate. I saw this in my own state, very difficult for people to enroll in these programs, to know that they're even out there. They don't talk to each other. You have public health programs over here like WIC and Healthy Start, and then you have Medicaid over here, and never the twain should meet. And so our company is a connector. It is a primary care company for Medicaid families with young children. Why Medicaid? Because Medicaid families, I think, need this the most. A one-stop shop with home visiting as the primary way of engaging with families, that's done by community health workers. And then the community health workers are impaneled by a team of caregivers that includes specialists in behavioral health, in pediatrics, a midwife, a nurse, that can then help take care of that family. So that family doesn't have to go all over God's earth to get the care they need. The care comes to them. So I'm very excited about it. I think this is a company that addresses issues of health equity. I'm always shocked. Liza and I were talking before this call, and Brenda and I, about we count the dots, we don't connect the dots. We throw up our hands and say, oh, look, here's the health disparities, and they're so awful, and here's the numbers of them, and here's the outcomes, and Black women are dying at 2 times the rate, and Black babies are dying at 2 times the rate, and look at all of this, and then where's the solution? So I want to be a part of the solution. I really think if we don't care for our caregivers, for our mamas, and our dads who are trying to raise a family in this country, and make it easier for them to get health care. And by the way, other things like make sure they have decent wages, make sure they have family leave, and all of these other things, we're going to continue to struggle to get health equity. So this is a healthcare piece, but it's very important, and I'm really excited about it.
And did you just launch Nest?
We just launched the Nest. Yeah, so we launched in December, and we're growing and excited about the possibilities. We really want to transform healthcare for all families. And this is something that my family could use. So our hope is that there'll be a new vision for healthcare that's really based on well-being too. One of the things that I learned when I went to Cuba many years ago was that with not very many resources, you can create health through behaviors, the exact things that Liza is focusing on. If you eat healthy, if you walk, if you have a healthy mindset, I'm not saying that solves poverty, and I'm not saying it solves racism and racial injustice and all of these things, but it is an important piece of health. And so that's where our health system fails, and also what we aim to focus on.
I love it. Both sound like models that could be emulated nationwide. So I don't know if that's something you two dream about, but you both pinpoint, I think, pain points for women, but also anyone with women in their lives, many of us relying on women for caregiving. So thank you on behalf of the communities you're serving. It's amazing. So America's been given an up-close view through the media of how COVID-19 has unmasked long-standing health disparities. How do health disparities show up in your practice of gynecology and in caring for women and families?
You know, it shows up every day. I think we see issues with access to transportation for their office visits. You know, I've actually dedicated my career so far working in community health centers. You know, I want to be part of the solution. So we see, you know, if these women go to other practices and they're 15 to 20 minutes late, they may be turned away, but they have taken 2 buses to get to your appointment, which are unpredictable. You know, educational access has been an issue. So women coming in for their gynecology appointments may not know how to advocate for themselves because they're not aware of what they actually need. There's no system set up to say, these are the guidelines. This is what you need to care for your body. These are the preventative health guidelines that you should follow. I mean, we get more for our cars that need to be serviced than women actually get to take care of their health and to keep up with what is actually needed is very daunting. So fear can be paralyzing for some people. I think disparities also show up in access to services. I'm a minimally invasive surgeon. I do laparoscopic and robotic surgery. And, I think I'm the only minimally invasive surgeon working in Boston community health centers right now. And we have, I think, about 52 in the entire state. And the reason why this is an issue is because they have seen that Black women, women living in poverty of any race, are less likely to get offered a minimally invasive procedure, a laparoscopic or robotic procedure. There's studies in the last 2 years showing that even if the equipment is available, they're less likely to get these surgical options. They're less likely to get pap smear screening. I think disparities are also showing up for me, particularly with Black women. There's been a real push to educate them about fibroids. I mean, I can't tell you the number of Black women who have found me in my practice, who haven't had a pap smear, who haven't had an internal exam, which is we call a bimanual exam, for years. And so they'll present with their menstrual abnormalities, so maybe their menstrual period is longer or they have anemia, and then you'll do this internal exam and find fibroids that have just grown out of control. And so a procedure that you could have done with small incisions, we're now having to do open procedures, which has been rare in my practice. But it's after COVID-19 and with the data that was being discussed, where they're actually promoting the benefits of having a provider of color. So Black women being treated by other Black women, there's been a push. So women are saying, oh, I want to find a Black gynecologist and maybe get a second opinion, maybe have this surgeon look at my case. And so these women are coming in, and I'm seeing an increase in the number of fibroids that are just grown so large. There's no space to offer these minimally invasive approaches. I think that disparities also show up in resources. I mean, we talk about equity versus equality. So if you're working in community health centers and these patient populations require more resources for their care, we should have even more nurses to triage those phone calls. We should have more resources to help figure out if there are transportation issues or issues with, achievement gaps or education. If they're, and therapists, there's a real shortage in therapists for behavioral health, even though there is this big sexy push across the country talking about mental health. I have to tell you, as a provider, it has been very challenging to find therapists for my patients, therapists that actually take insurance. So these are the things that are actually showing up in my day-to-day practice. Resources is really key. I think one policy that we need is there should be a certain amount of resources per patient population that you're caring for. A private practice who has half the patient population than a Boston community health center should not have 4 nurses on staff and the health center has 1. Because if a patient is calling with chest pain or heavy bleeding or a major issue, shortness of breath, and they can't get a nurse on the phone, they can't get their phone call triaged, we're talking about a medical event that could have been caught earlier, and there could have been a better outcome that is now, the patient is presenting later. There could be an increase in heart damage. There can be, more problems that are going to happen downstream because they just couldn't get their questions answered. So I think resources is also something that I'm seeing. And I just think there needs to be more of a focus on prevention as well. As Rebekah talked about with NEST, it's just brilliant to offer educational services in childhood and pre-pregnancy. She and I have discussed this. There's a study that looked at adverse childhood experiences called, in 1998, and it was done by Kaiser in California. And they actually found that a difficult childhood was more likely to predict healthcare problems in the future, healthcare problems that were directly related to early death. So you're more likely to be an alcoholic, abuse drugs, have multiple sexual partners and unhealthy, risky sexual behaviors, have even shown increased risk of cardiovascular disease, and all types of healthcare problems that, just because you had a difficult childhood. And so what Rebekah's speaking about in Nest is so important, because there needs to be focus on building resilience. And we love to use the word resilience, but what does resilience really mean? It's how does someone overcome hardships? So some of us are born with a set point, and we maybe just be able to let things roll off of our back a little bit easier. And some of us need more help. And so moving in the lens of how do we create a system that works for everyone is really where we need to be. And that currently doesn't exist. I think it's money that drives healthcare, and instead of really looking at programming. So I think if you look at some of these grassroots organizations who've been able to accomplish amazing things in the areas of social determinants of health, like housing equality, look at for instance, Habitat for Humanity in 1970s. They started empowering communities to not only help build their homes amongst volunteers, and a lot of these communities were African American, then they would actually have a home and a stable place to raise their family and an affordable mortgage. Or look at Alcoholics Anonymous, for instance. This was started by two men who wanted to be sober, a medical doctor and a financial analyst. And they published a book about the journey of the first 100 men. And this grassroots movement, the only requirement to join is that you want to be sober. And it's grown. There's over 2 million members now. So I think we need to be visionaries, and we need to create solutions. And funding needs to change. We should be funding solutions and seeing how they work, instead of funding individuals to keep presenting the same data. So I think that's a major disparity. I mean, trying to get something funded that's working with consciousness for women has been, it's a challenge. Everyone wants to ask, well, how are you going to scale that? Well, in order to scale it, I first need to make sure that Health Vows works well. I need to make sure that women are benefiting from it. And that's what I've been working on for the past, 6-7 years.
Yeah, it's amazing the startups that can be funded in certain spaces, but it's like everyone wants all the answers in healthcare, before you've even tried it out. Yeah, thank you. Rebekah?
Yeah, so many ways. So I think certainly in the South, I have been a party to multiple things that have been really shocking that have been said to me because I'm a white woman. So for example, and so 10 years ago, I started an effort to improve birth outcomes for the state, and I traveled the state and worked with providers and worked with hospital leaders to look to see what we could do to reduce admissions to the intensive care unit for babies, and how could we improve outcomes for moms. And it was really shocking to me how few providers really wanted to see patients who were of color or Medicaid patients. And one day I asked a provider, why don't you see these women? And he said, well, we got rid of our Medicaid day because we don't like how the waiting room looked when those women were in it. And we certainly didn't like their children with their McDonald's dipping sauces. So just, blatant racism, it was shocking. And so one of the things that I did when I was Secretary of Health was found an Office of Health Equity. It was the first in the South in a health department. And I think one of the things that we need to do is to have consciousness about our bias. I think obviously this has become politicized. It shouldn't be. We all have bias. If we're not something and somebody else is, we're going to have a bias about it. And they're going to have a bias about us. And that's okay, but it's about recognizing the bias. It's about not leading with bias. It's about understanding where that bias might make you to make a decision on someone's behalf that doesn't actually relate to them, doesn't make sense for them. And so we trained our whole senior leadership team and our the second layer of staff down on bias and how it influences our decisions, whether it's, I'm not in a wheelchair and I'm making a decision on behalf of someone in a wheelchair, or I'm white and you're black and making a decision on behalf of you. So I think that was really important. I think the other thing that was shocking to me were just the the politics around Medicaid. So Medicaid for me is a no-brainer. There were all of these efforts, of course, to force people to work, to get health care, which doesn't make any sense, because if you're sick and you can't, you have difficulty walking because you have arthritis, you're going to have a hard time working. You're going to have a lot better shot at working if you're actually healthy. And so, but a lot of this comes from racial bias. A lot of the legislative members and folks who were opposed to Medicaid were opposed to it because it was helping individuals of color in part, and obviously low-income people. But I think that there was a sense of the undeserving poor getting these services, and that was infuriating to me. And I saw it play out in state government programs that predominantly impacted white children. Cystic fibrosis, let's say, versus sickle cell disease, or a program helping lower income kids who have disabilities that white families were advocating on behalf of was getting a lot better support than programs helping families of color. So it's just, the bottom line is that racism still exists, racial bias exists, and because of it, there are also health care disparities. Until 2016 in Louisiana, if you were a low income adult in the state of Louisiana, you could not get health care unless you had such a horrible disability that you could barely walk, or you were in a nursing home and were eligible for Medicare. And so that's the kind of thing that creates the disparities that we see. And then finally, I think one of the most shocking ones that I saw was the maternal mortality data. So we aim to take on the issue of maternal death. I mentioned earlier that Black women are twice as likely to die as white women from pregnancy. And so we looked into it and said, well, maybe, could be that women are sicker. But by the way, it wasn't that women were sicker. What we found was that 59% of the time, if you were a Black woman who died in pregnancy, it was preventable. Almost 60% of deaths were preventable. But for white women, 9% of deaths were preventable. So there was so Black women weren't getting blood as quickly as white women. Black women's blood pressure wasn't being addressed. Black women would complain of pain and they were ignored. We've heard this from Serena Williams. We've heard this from many people. It's not just about income, it's about racial bias. And so we set out to address it. And I'm excited to say that we have made significant progress on both disparities in maternal health and maternal death. But the bottom line is, you can't manage it if you don't measure it. You can't manage it if you don't address it. And the very first meeting we had with our hospital teams, where we talked about racial bias and we talked about racism, we had about 3 hospitals just walk out of the room and say they weren't comfortable, they won't talk about it. Those same hospitals later on re-engage. So I do think it's important to meet people where they are and on that journey, because we've all got to change. We want society to be equitable, but we have to meet people where they are. We have to be able to have conversations. That was probably, of all the work that I did in state government, the most rewarding.
Yes. Wow. Some of those stories are hard to even believe are true, and I know they are. So how does your commitment to eliminating health disparities show up in your work, Liza?
I think firstly, just in my choices to work in community health centers, it's a comprehensive model where you can have primary care and different specialties all in one area. So there can be easy access for patients. And, when Rebekah was talking about all she does for her family, this is true for all women. Women typically are the stewards of healthcare in their families. They're scheduling their kids' appointments, they're scheduling their partner's appointments. And so for me, I wanted to, live from the inside out and actually place my expertise and my passion and my desire to actually lift up women, not only in helping to treat disease processes, but also lift them up in consciousness, one patient at a time. So, I serve in the health centers for that reason, just because of my desire to make sure they have access to every type of gynecologic procedure they may need, unbiased counseling. I'm really into education. So I'm not someone who is going to say, push them to get a surgical procedure. I'll say, let's try invasive things first. And depending on the patient population, some are very trusting and you have to say, wait a minute, you don't need a hysterectomy. Let's try this. And some are very suspicious and they need time to warm up to me. And I have to respect that woman and her individual thinking and meet her where she is. Every patient wants to feel seen, heard, and understood. So this is why I choose to work where I work. And I think doctoring is part of the solution. So, and that's why I've taken the charge. You can't have a big ego to focus on clinical care in this country because it's often not really rewarded on a day-to-day basis, but it's rewarding for me when I'm alone and looking, in a mirror, and when I'm alone in a quiet room. And so that's one way that I choose to serve, is just by, always thinking about, what do women need? How can I be a source and an outlet for these women, and provide these safe procedures if they need surgery, counseling, education options. And each woman that I meet with, I really believe in taking care of the whole patient. And so the whole woman, and that's really important because every interaction that they have with us is going to determine how they may have other interactions if they have other issues that need to be addressed, and how they're going to navigate the rest of their healthcare journey. So I think that's one way that, I really work to eliminate disparities in my practice. I think even with health vows, I facilitate these workshops in off hours so that I can capture more participants. So that's another way that I work to eliminate disparities, in the sense that, if you don't focus on individual behavioral change, I think if we don't push women to be more empowered, teach mindfulness tools, teach coping skills, improve health literacy, we're going to be seeing the same reports of disparities and inequities for decades to come. I think the other way that I work to eliminate disparities on a day-to-day is just staying true to, how I felt when I was a medical student. I was recruited by University of Illinois College of Medicine's urban health program. And I remember when Dr. Hiroti called me, he said, you seem like someone who's going to serve in the urban community. You seem like you're going to serve people that are overlooked and people who really need access to care. And I really took that seriously. I mean, they obviously saw that in me from my track record of how I volunteered and what I did in undergrad and before then. But, my experience growing up in the Midwest, growing up in Chicago, where we were trained not only in community health centers, but in community hospitals, the university hospital, and private hospitals, we were taught to treat every patient with dignity and respect. And it was a really beautiful experience. And just, I think, navigating that medical school journey, they're heavily involved as being game changers in producing clinicians of color. So this can be, my medical school class had African Americans, people that, from Indian descent, Asian descent. I mean, it was so diverse. And, University of Illinois College of Medicine in Chicago, they were really serious about educating people of color, because they know that we are more likely to go back and serve these underserved communities that really need to be placed on an equal playing field. And it starts with us as providers. Another way, and then I'll let Rebekah take over this question, that I think that I really want to mention first is just in communication. So there have been studies that have shown that patient clinician communication is really key to promoting health equity and eliminating disparities. So they found that, clinicians who are not culturally competent, who are biased, and we all have biases, like Rebekah said, we all inside have a propensity or gravitational pull to certain types of people, probably what we know best, but it's about being conscious about that. So it's in the communication with patients that disparities show up. And when I run these workshops, we get that out. Women are expressing, I don't feel seen, I feel rushed, the doctor's not answering my questions, they're on the computer too much. So I actually have been very mindful from day one of that doctor-patient interaction, because I know I represent not only every doctor, but also I'm a Black female doctor. And even whether you're white or Black, you know, the way I act and carry myself is very important to establish trust. And if I'm really serious about doctoring and help and creating healthy environments for my patients, I have to be mindful about how I communicate. Look patients in the eye, ask them, do you have questions? Answer their questions. Don't be on the computer typing notes, you know, while we're talking. Overly educate, be available, and care, you know. So that these are just a few ways that I show up trying to create equity in my day-to-day work.
Thanks, Liza. Well, earlier I talked a little bit about the work I did at the health department. I think in general, what I tell mentees and other folks is wherever you are, when you see inequity, address it. So when Liza and I were in residency together at Harvard, I saw a patient who needed Plan B. Walmart refused to give it to her. And so I sued Walmart along with some other women, and we won. And you know, when I saw that patients didn't have access to hepatitis C drugs because they were so expensive, that we would have to pay more for their treatment in aggregate than we had for the entire state for K through 12 education, we decided to change it, and we were successful. So I think part of it is about, it's like, I always describe it as being a dog with a bone, is when you see injustice, you address injustice, then in the ways that you can. And everybody has different tools. Everyone has different things that they see. If someone says something in a way, if somebody does something, if you see something that's not fair, something's not set up, change it. Or if you're practicing medicine, think about, as Liza said, how you talk to patients. I think I still have the gift of seeing patients, and when I do, really lean in with them and hear what they have to say. And that's what makes healthcare joyful, is having that trusted relationship and that bond. So I think it's about addressing inequities when you see them. But it's a big challenge, because this is a country that is highly inequitable. If you look at the just economic inequities in this country, you have a small percentage of people that own most of the wealth, and it's not enough in this country anymore to have a full-time job. You know, the dignity of that, you know, people say, well, dignity of work, well, that's great, but if you have a full-time job and you can't put a roof over your head, and you can't pay for food for your family, then it's just, then we're talking about an impossible situation. So again, I think that we all have to address power structures and access and inequity when we see it. And I certainly think in the American South, where Liza talked about Chicago, we both trained in Boston, the models that I saw there were very, in my view at the time, were incredibly patient-centered, focused on each person as a treasure. And then I came down to Louisiana, and it was, okay, if you're in Medicaid, you all have to show up at 8 a.m. Everyone sits there for 5 hours. We don't care about your time. We don't care that you have kids here. I'm talking about when I first moved here, that you have to care for while you're waiting to get yourself cared for, because you don't deserve it. And that was still happening when I moved here. It was shocking. And so part of it is about, you know, dealing with things where they are and just saying, look, this has to change. This is not the norm. And I think I've been fortunate, as has Liza, to practice in some settings that were extraordinary. But I also think there's a big part of physician burnout. I gave the graduation speech at Tulane a couple of years ago, and I talked about the white coat being like Harry Potter's coat. It's magical, and nobody else has that unearned trust like a physician does, or a nurse does. You know, you have clergy, that would be the only other, I think, parallel, where you just trust because they are. And it's just such a gift. It's such a gift of wonder to be able to, as Liza does, look inside somebody's body, or to hold their hand while they're dying, or to care for them while they're giving birth, or to hear them as they talk about their pain. That's a gift. And so if we can take care of ourselves, back to being mindful, if we can take care of ourselves, then we can be reminded of that, the gift that is. And then we're going to be better able to care for everyone equally and not have that bias come in. Because I do think if we have equanimity within, then it's easier to promote health equity and equity for people that we encounter, because we're at peace with ourselves. And so I think that's part of what our society needs, having been through a really tumultuous time in the past few years politically. People are on one end or the other of so many issues. It's about, can you just be at peace, stop arguing, and just listen?
When you two talk about how you interact with your patients, it makes me, long for a time when that shouldn't feel special or unique. I know so many times I've left not clear on what's happening, scared, kind of frozen with fear, and angry that there isn't more time or a way that I can, just process and comprehend and do the right thing. It's even more complicated when it's your children, right? And you're just scared about their safety. So I appreciate what you two are creating for your patients. I hope more of us, have that kind of experience going forward. We've grown to expect so little, I think, from our providers. It's just scraps feel generous. And I think you two are changing that. And it's exciting to think about a future where that's available for everyone.
Thank you.
So we're coming. Oh, go ahead.
I have a comment too, hearing Rebekah talk about her experience in the South, and we have a shared journey in that. I spent 5 years in a different state. I left Boston. I ended up coming back in 2014. And the fact that the hospital systems where I worked did not take Medicaid at the time, and the conversations that were being held behind closed doors about Medicaid patients, everything you're saying, Rebekah, I don't think you and I really had talked about this. I couldn't sleep at night at times. And the reason for that, Rebekah and Brenda, is because I was a Medicaid patient. I was a Medicaid patient when I hit around the age of 16. Before then, my parents nor my 4 other siblings had health insurance. And I was on Medicaid for 2 years. And then I first had health insurance because I went to Northwestern University, where it was required to have, if you were matriculating, and they supported their students who were from socioeconomic disadvantaged backgrounds. They even had dental grants. So if I needed, it was the first time I was able to continue dental care, because with Medicaid, I could from 16 to 18. So what you're saying, Rebekah, hit home. And even though I had a comfortable home for half the price I pay in Boston, I used to dream of coming back either to the Midwest or Boston, because I thought, how can I practice medicine in an environment that talks about Medicaid patients and doesn't want to take Medicaid, when I used to be a Medicaid patient? My parents were uninsured for most of their life until they were, able to receive Medicare. And my father recently died at the age of 70 in August. And he died of fear, really. He had a chronic autoimmune condition. And, he died of fear because you don't lose over 120 pounds in 5 years and don't go see a physician. And he was a white man. He's a white Jewish man. And so, but he and my mother, just had a fear of physicians, and who knows what they saw growing up in the history of America, growing up during the civil rights movement. I mean, they were married 5 years after the Loving Law, where interracial marriages were even legal. And so these topics really hit home for me, and hearing you talk about how patients on Medicaid were perceived, because I went through that too. When I first left Boston, where I was used to doctoring and not looking at a patient's insurance card, meeting women, I met women that were suicidal and nobody would see them because they were on Medicaid. I had never seen so many women showing up to the emergency rooms with cervical cancer and endometrial cancer, and they had been seeing primary care physicians but hadn't had pap smears. So what you're saying, Rebekah, when you have been working in policy, I can only imagine, and I've often wondered what your day-to-day job was like, because I know what I felt like as a physician. So you must have had to have amazing courage to stand among policymakers and speak up for this body of people that are as important as anyone. I mean, if we worked in a feeling tone of oneness, we are all worthy of care. We're all so worthy. You know, what would America look like?
Well, and that's a perfect segue to our final question. So what do you see as the biggest challenge America faces in addressing health disparities and inequities through the lens of being a physician?
From a physician's lens, the biggest challenge is, disempowering physicians to actually practice medicine and practice their gifts of caring and doctoring for patients. And we are not empowering and educating patients enough. That we know with historical data and what's happened in this country and with studies like that look at the childhood ACEs, that we need to empower people and teach them how to navigate these complex healthcare systems, how to work with doctors, how and teach them, this is what you actually need to live healthily. These are guidelines, and without that, I don't see how anything will change. And we're moving towards, there's a lot of government in healthcare, and government nor private industry plays by the same rules that we physicians are told we have to play by. So we took an oath to take care of patients, but you see, the major influences of politics and industry on healthcare, and even what people are ingesting in terms of information. So sometimes you have, money talks, and so people are learning misinformation online, or they're going to, you don't see doctors delivering that information. And we're moving to a value-based care model. There is no area in the value-based care model, which is what they're looking towards moving us to, for patient buy-in, for patient accountability, for patient empowerment. And I think this is a real issue, because they're further putting this expectation on the clinician that in a 15 to 45 minute visit and beyond, we're supposed to make these major healthcare outcome changes, where there's a saying, you can bring them, what is it? Bring a man to a well, but you can't make him drink. We need patient buy-in. We need patients to be individually empowered and be an active participant in their care. But also we need, policy and investments and programming to actually further the cause of creating a healthy world and healthy America. And the government should be held the same standards in private industry that healthcare workers are. So I think that's the biggest challenge. Physicians staying empowered to do what they're meant to do, empowering patients to navigate these complex healthcare systems, trying to work also with individual behaviors of individual physicians and hospital administrators, and the hierarchies that exist so we can look at our own conscious and unconscious biases and make different choices when we're approaching patients. People can come with the same complaint, but they're going to come with a whole different background. So you can have two women who show up and they're having bleeding in menopause, and they both need the same procedure, but they're going to each come from an entirely different background with different mindsets. And there's going to be differences in how we actually approach that woman and make sure she gets the biopsy she needs so she doesn't have cancer. So how do we ensure that both of those women have an equal chance at getting that biopsy, having cancer ruled out, and getting the procedures that they need? How do we do that without empowering physicians and patients, and making sure that we don't let healthcare continue to just spiral out of control and out of the hands of patients and clinicians? That's what it's feeling like to me.
So I think if we're looking at disparities in healthcare or in health, it's two different things. I mean, I think we've talked a lot about disparities in healthcare. They're real. Of course, to eliminate disparities, you have to have universal access to healthcare. But beyond that, healthcare is not enough. You need a society that supports wellness and well-being for all people, regardless of their background. And so we're a long way from that. And I think partly the problem is that the power structures don't support that. I think of a problem, recently I served on a review panel for the NIH looking at focus on contraception and looking at some of these other issues that are really, really important for lower income and for all women. And the bottom line was almost no money is spent on this. Why? In my view, it's because women haven't been in charge. Women haven't been making the decisions about where funding goes. People of color haven't been in charge. People of color haven't been making the decisions about where things go. And so it's whatever the man's priority is, has been addressed. Why don't we have universal childcare? Why don't we have paid family leave? Why? Because women are not in charge. That's, I'm simplifying it, but when I started my role as secretary, only 9% of the Louisiana legislature were women. And so I think we have a long way to go in terms of changing the voices that inform society's priorities. And I don't think it's and this is where my friend and our mutual friend Brenda Eric Longshore comes in, is that he thinks about it not as a scarce society, not as a scarcity mindset. This is a society, we are in the greatest period of innovation and business growth and growth of ideas and opportunities in human history. And there's plenty of room at the table for everyone. So I don't think it means that people have to get kicked out or it's the end of the white male in charge. It's the fact that you have to add more chairs to the table. You've got to create spaces and places for voices for change. And through doing that, but you also have to create economic opportunity. You can't have one person who's CEO of a company who makes tens of millions of dollars and then a frontline worker that cannot feed his or her family. These things have to be addressed, and they do have social consequences. They create disparities in economic opportunity, and fundamentally, health, in my view, although I've spent my life on healthcare, is so much more about emotional well-being. It's about the economic opportunities you have. It's about feeling safe. It's about education. Those things are so much more important than healthcare. Although healthcare is a human right, we should be giving people healthcare. No one should go without. As a daughter of someone who died of breast cancer, I believe that so firmly. And someone who spent 3 months in a wheelchair needing healthcare because I was in an accident. But that's the foundation. It's our souls, our spirits, our well-being. Those things are fueled by these other things. And as a society, we've got to be very critical, I think, in these times about inequities and why they're there and how do we solve them. And I think it's a really great moment. I do think if there's a silver lining for COVID, it's that we all recognize the disparities exist. So many more companies and individuals are thinking about their role that they can play in fixing and ending disparities. How do they create health equity through their own lives? How do they teach their children different lessons? How do we evolve as a society? And I see a lot of really positives out of what's happened in these past 2 years, including with my own children who are very aware of these issues and looking to see how they can change the world, just as you are with Mindful. It's been so nice to be with you, Brenda, and you, Liza, and an honor to be interviewed. And I just wish all the participants and those who were able to hear us well-being. If you're a clinician, take care of yourself. And it's been an honor to be with you.
Oh, thank you. The honor's been mine, and I know I speak for our audience just to say thank you. If you want to learn more about our topic today and our brilliant speakers, Liza and Rebekah, please check out their profiles on Whova, and you'll also find links to their website there. I also want to just remind our audience that Mindful offers dozens of digital courses that you can consume and take at your own pace. They're all led by expert mindfulness teachers and designed to be useful and practical in your everyday lives. You can find a wide variety of them at learning.mindful.org. And finally, please rate this session before you leave. There's a rate session button below the video in Whova. It'll only take a minute and your input is really helpful. Thank you for being with us today and stay well. Bye, ladies.
Thank you both.
Thank you.